Thank you very much, Jarek and Dr. Verdostek. It's a pleasure to be here. This is a little different flavor talk. I'm going to concentrate more on the cellular aspects of MDS and the role of stem cells in this disease. So, I don't have to tell this audience that we need to make a lot more progress in MDS and elderly AML. These are survival curves that show 4 decades of treatments for these diseases, and as you can see, it's still a lot of work to be done. And one of the main problems in these diseases is that frequently, at least in AML, you can put patients in remission, but relapse is a big problem. And when they relapse, as we know, we don't have very effective therapies. The cancer stem cell hypothesis has been studied for many years, and this is a very simplistic diagram which shows that according to this hypothesis, a tumor or a malignancy does have heterogeneity in terms of its cellular composition, and you can have blast-like cells, but you also have transformed stem cells that make this malignant stem cell. And you can mop up the blasts or dividing cells with chemotherapy, but it doesn't usually hit non-dividing cells, and then the cancer stem cells again leads to a reconstitution of the tumor. So we wanted to, a few years ago, find what's happening in myelodysplastic syndromes and how the stem cells are altered in this disease. Now, the thing with this is that phenotypically, if you look in an AML or an MDS, you will find stem cells in the bone marrow and progenitors, and phenotypically, they don't look any different than normal stem cells and progenitors. So and this shows the hierarchy of, where's the pointer? This is the pointer? Okay. So this is the hierarchy of hematopoiesis. You have stem cells, a variety of progenitors that give rise to differentiated cell types. So using very rigorous lineage depletion, we took out all the lineage positive, all the differentiated cells from the equation, and then using a variety of markers, we separated stem cells and a variety of progenitors, and we sorted them by flow sorting. And then after that, we analyzed them transcriptionally. We also analyzed them epigenomically with downstream assays. So the first thing we noticed was we analyzed about 15 MDS bone marrows, lower risk and high risk, and compared them to 15 controls. What we found was that there is a definite stem cell expansion that we see in MDS. So if you look here, these are long-term stem cells, these are short-term stem cells. We start seeing an expansion of these earliest phenotypic stem cells in MDS, and this expansion is most prominent in higher risk MDS. When we look at progenitors, we notice a pattern that in lower risk MDS, we find that the common myeloid progenitors are elevated quantitatively, and in the higher risk MDS subtypes, you find an increase in the granulocytic monocytic progenitors. So the sort of working hypothesis that we had was that you have this hierarchy of differentiation, stem cells to multipotent progenitor, common myeloid progenitor, GMP, and this megakaryocytic erythroid progenitor. This is what happens normally. Now you have an mutation or an epigenetic event that occurs in the stem cell compartment, and in lower risk MDS, we find that there's a differentiation block at the common myeloid progenitor. We see much more of these, and we see very reduced numbers of the megakaryocytic erythroid progenitors, which can potentially explain the thrombocytopenia and anemia that we see in these cases. In higher risk cases, we find a much more elevation in the numbers of long-term stem cells. But we also find this GMPs that are expanded, and there have been multiple studies now that have gone on to show that these GMP populations can actually act as leukemia-initiating populations. So these can give rise to leukemia. Now, we do find expanded stem cells. Are these normal or are these abnormal? So when you look at them in vitro, they are functionally quite deficient. They don't give rise to erythroid and myeloid colonies as effectively as normal stem cells. They can look, they can give rise to these Pelger-Hewitt-like cells when you culture them, MDS-like cells. But interestingly, when we sort these HSCs from MDS samples and then probe them via FISH for cytogenetic alterations, we find that there's actually, these cells are very enriched in cytogenetic alterations. So this is, when you do a bone marrow, you send it for cytogenetics and FISH. The results that you get are from the whole bone marrow. And in our cohort, we found that 50 to 60% of whole bone marrow cells were affected on an average. But when we look at these enriched populations, more than 90% of these early progenitors and stem cells have these cytogenetic alterations. So they're quite abnormal. We sorted them and we did whole genome analysis of DNA methylation, and we found that these stem cells actually had a high number of genes that were aberrantly methylated, as well as genes that were aberrantly hypomethylated. They lost their methylation. And they also had changes in their gene expression profiles. And then we tried to find out if there was any correlations in genes that were significantly overexpressed and then lost their methylation. And one of the targets that we found was this transcription factor STAT3, which is downstream of a lot of cytokine signaling cascades, including JAK2 and some other oncogenes. So STAT3 was, when we validated in bigger cohorts, was actually raised in a lot of MDS subtypes. And as proof of concept, we showed that if you use STAT3 inhibitors, these agents, these small molecule inhibitors, can actually selectively target MDS stem cells. They do have some toxicity against normal stem cells, but there is a therapeutic index that seems to exist. So now we're testing some clinical STAT3 inhibitors, and hopefully we'll have some data in next year for this. But I think these studies tell us that MDS and AML, especially MDS, is a stem cell disease. You do have aberrant pre-leukemic stem cells that have a host of genetic and epigenetic abnormalities. And there have been multiple studies now from many different groups that show similar findings. And we looked at cytogenetics. We're looking at mutations now, but Dr. Maggetti's group from Stanford and Dr. Dick's group from Toronto have gone on to show that these pre-leukemic stem cells in these diseases have enrichment for mutations also, some of them that we've been listening to in the last few talks. Okay, so the question is, what can we do therapeutically? So I wanted to show you a case, very interesting case. We are in the Bronx, where still a lot of crazy things happen. This was a 42-year-old car mechanic who was working in a garage, and they were still cleaning, till a few years ago, car engines with benzene and organic solvents. And he was not using gloves. So both he and his sister actually working in the garage. First, the sister gets AML. We do an allo for her, and unfortunately we lost her. Her disease came back. Then this gentleman, a 42-year-old guy, presents to our clinic with MDS, and he had high-risk MDS. So at presentation, he had 10% blast, so he had the RAEB subtype. He also had deletion 7. When we looked at his whole bone marrow by FISH, 48% of the cells had deletion 7. We put him on a trial with azacitidine. These arrows are doses of azacitidine that he got. And he actually had a very nice response. You can see he was transfusion dependent. These are his blood, hemoglobin profile. Started getting ASA, hemoglobin rose, he became transfusion independent. And his blasts actually went down to 2%. So phenotypically, by pathology, we can say that he's in a clinical complete remission. At the same time, we were sorting his marrow cells, and if you look at his sorted stem cells, 99% of them actually had the deletion of chromosome 7 abnormality at presentation. Even when he's in clinical remission, 97% of his HSCs had this deletion 7. And then we found that in the middle of his remission, the numbers of these abnormal stem cells actually went up. And then unfortunately, 2 months down the road, he relapsed, transformed to AML, and unfortunately didn't do so well. So this case illustrates that even when we have patients who are in phenotypic remissions, they do have these clones of aberrant stem cells that are hiding in the marrow. And we really need to target them. So how do we target these guys? So we've been trying to do expression analysis of healthy and compare them to AML and MDS sorted stem cells. And from our initial cohort, we actually found a list of genes that were highly overexpressed in MDS and AML stem cells and progenitors. So we've tried to study their functional significance over the last few years, and I just wanted to show you 2 proof of concept studies quickly. So we wanted to, phenotypically I mentioned that when you look at an aberrant stem cell and a normal stem cell, it's very hard phenotypically to differentiate them. So we thought we should look for specific markers, cell surface expressed antigens that could differentiate them. And in collaboration with Dr. Uli Steidl, who's in my institution, we focused on this gene called interleukin-1 receptor accessory protein, IL1RAP, which is a cofactor of several cytokine receptors, including interleukin-1. This is actually a surface expressed protein. It is a big transducer of innate immune signaling pathways, which are becoming very important in MDS pathophysiology. So IL1RAP leads to IRAC activation, and there have been papers that show that IRAC4 and 1 can also be good therapeutic targets in MDS. But anyway, when we look for IL1RAP protein expression in AML HSCs and compared them to healthy controls, we found that this protein was very high in AML and actually some MDS HSCs. And this gene was also overexpressed transcriptionally when we looked at AML and MDS. And most interestingly, when you use IL1RAP as a marker, so you sort cells that were IL1RAP positive and then IL1RAP negative, we found an enrichment for -7 in the IL1RAP positive cells. So maybe this is marking these aberrant stem cells in AML. We found that IL1RAP high cells, so this is interrogation of the ECOG AML cohort. We found that IL1RAP positive AMLs did much worse than the IL1RAP negative AML samples. So this was quite prognostic. And then, I'll go through these very quickly. In vivo, when you knock down IL1RAP, you do xenografts. These mice do much better once you knock down IL1RAP with shRNAs. So to summarize this, discovery of IL1RAP seems to be a marker of pre-leukemic stem cells in AML and MDS. We've been trying to use this as a diagnostic markers in some in-house clinical trials. And we're also trying to use antibodies against IL1RAP to see if they could be therapeutic in this disease. Lastly, we also, when we did the transcriptional analysis, we found that interleukin-8, which is another human cytokine, was greatly elevated in AML and MDS stem and progenitor cells. These are sorted stem cells, long-term, short-term, and GMPs, the leukemia-initiating population. You can see there's almost a 2 to 3 log-fold increase in interleukin-8 in the AML and MDS subtypes compared to normal controls. We saw that this interleukin-8 levels were high even in public data sets, the TCGA cohort and an MDS cohort from Oxford. And the receptor on which it binds to CXCR2 was also high in these large cohorts of MDS and AML samples. And we found that if you have high levels of the IL-8 receptor CXCR2, these patients do worse than if you have low levels of CXCR2. So in the interests of time, I'm going to quickly go over this. So when you have high CXCR2, the MDS samples with high CXCR2 have a leukemia stem cell-like signature. When you have low CXCR2, they're more, less stem cell-like. And we are working with a small molecule inhibitor of CXCR2. It's a GSK drug, which they were using in lung diseases. And we showed that this small molecule can effectively inhibit a bunch of leukemic cell lines. And also, when you knock down CXCR2 in primary samples as well as leukemia cell lines, they grow much less. I'm going to show you. The last thing I want to show you is that, interestingly, the big thing with all of these stem cell active agents is, do they have adverse activities against normal stem cells also? And the big challenge in this field is to find agents that are more selective for the leukemia and MDS stem cells and not so much for normal stem cells. So interestingly, CXCR2 inhibitor showed pretty specific effects. This is AML. This is CD34. This is CD38. So the 38 negative, 34 positive fraction is the HSC fraction. And you can see that when we treat with this drug, we find increasing cell death in AML sample HSCs, but we hardly see any difference at all in the normal stem cells. So we think that the IL-8 CXCR2 pathway seems to be quite nicely selective for MDS and AML stem cells. And we've shown this in vivo also. So to summarize, there are quantitative as well as qualitative alterations in MDS stem and progenitor cells. These aberrant stem cells do survive during morphological remissions. We need good therapeutic targets against these stem cells if we are, aiming for curative therapies. Unfortunately, the only cure is still with an allotransplant, in which you are actually targeting the stem cells. And some promising targets preclinically that are being now explored with clinical agents is IL1RAP, the IL-8 pathway, and STAT3. So thank you very much.